Module 2, Complex and Emergent Cardiovascular Disorders. So we'll be talking about coordinating care for patients with cardiac dysrhythmias. The first part is going to be a review of what you learned previously in Med-Surg 2, and then we'll get into the new content for this course. We begin with our conduction system. So our conduction system of the heart is an electrical system that begins with these specialized muscle cells that can produce an action potential. So this action potential is going to start in the sinoatrial node, the SA node, to create a sinus rhythm. So this electricity is then converted via an electrocardiogram, an EKG, into something that we can see as waveforms. So you can see here we have the P wave, QRS complex, and T wave.
Let's take a closer look inside the heart. The yellow objects you see on the left are not nerves. They're actually specialized cardiac muscle cells in the walls of the heart. Their job is to send signals to the rest of the heart muscle and cause a contraction. Together, this group of cells is called the cardiac conduction system. The main components of the cardiac conduction system are the SA node, AV node, bundle of His, bundle branches, and Purkinje fibers. Let's follow a signal through the contraction process. The SA node starts the sequence by causing the atrial muscles to contract. That's why doctors sometimes call it the anatomical pacemaker. From there, the signal travels to the AV node, through the bundle of His, down the bundle branches, and through the Purkinje fibers, causing the ventricles to contract. This signal creates an electrical current that can be seen on a graph called an electrocardiogram or EKG. Doctors use an EKG as a way of seeing how well the cardiac conduction system works. Any changes to the EKG can mean serious problems.
So what does the word dysrhythmia mean? So that just means irregular rhythm. You may hear the word arrhythmia. We're going to use that interchangeably with dysrhythmia. So that just means an irregular rhythm. So the pathophys on this, this is a disruption in the cardiac conduction pathway. So that electricity that we just talked about, there's something wrong, there's something amiss. So that's going to result in an irregular rhythm. So deviations in normal rate or rhythm can also be considered as a dysrhythmia. So if you have a patient with a regular rhythm but has an above normal rate, we call that tachycardia, or a below normal rate, bradycardia, we still consider that a dysrhythmia. So one thing that you need to remember is that dysrhythmias can be asymptomatic or symptomatic, and you need to know how to treat asymptomatic versus symptomatic. So if you have a patient with a dysrhythmia and they are asymptomatic, they're not going to be your priority patient. But if you have a patient that is symptomatic with a dysrhythmia, then that patient, their heart, their body is no longer compensating. So that is going to be your priority patient. So what are these symptoms that we're talking about? These are all related to reduced cardiac output. What is cardiac output? That is the amount of blood that the heart pumps out in 1 minute. So if you have decreased cardiac output, that means there's not going to be enough blood coming out of the heart that's oxygen rich to adequately supply the rest of the body. So that means that our cells, our tissues, our organs are going to become hypoxic, in a state of hypoxemia. So we want to make sure that we can pick up on these cues and assess our patient when they're showing signs of reduced cardiac output. So these signs and symptoms include palpitations, hypotension, diaphoresis, shortness of breath, syncope or even near syncope, lightheadedness, weakness and fatigue, dizziness, and anxiety. So a patient has a dysrhythmia plus any of these signs and symptoms, they need to be treated urgently. So risk factors for dysrhythmias, there are a lot. So there's more than just this list. But just getting older can lead to a dysrhythmia. Those cells that we have in the nodes, like the SA node, the AV node, they kind of die off as we age. So that can lead to a dysrhythmia. Myocardial infarction. So this means you've had some ischemia to the heart muscle tissue. and there has been some tissue death in that muscle. So that means that could also turn into a dysrhythmia. That can interfere with the electrical conduction system. Hypertension, valvular disease, heart failure, cardiomyopathy, infections, diabetes, sleep apnea, heart surgery, and pretty much any surgery in the thoracic area. Electrolyte disturbances. Remember that electrolyte imbalances can lead to dysrhythmias. Recreational drug use, alcohol, smoking, and many medications um, when they become toxic, especially digoxin, can also lead to dysrhythmias. So now let's talk about the electrocardiogram. So this is a graphical representation of the heart activity, and there's special ECG paper. So we're going to talk about this in just a moment. So we have our 5-lead ECG and our 12-lead. So the 5-lead is what we put on the patient when they have continuous cardiac monitoring in the hospital in the bed. Those are the 5 leads we put on. The 12-lead EKG is like the one pictured here. Many, many more leads, many, many different views of that electrical conductivity. And with this 12-lead EKG, you can read to see where exactly the problem is in the heart. So these are the waveforms that you will see. We have our P wave here, our QRS, our T wave, and our U wave. So let's start with the P wave. So our P wave comes right before our QRS complex, and the P wave represents atrial depolarization. So the atrium are contracting. So we want to see a P wave before every QRS because that is how the sequence should be. Our atriums they contract, and then our ventricles contract after that. So P waves are referring to atrial contraction. Next are the QRS waves or QRS complexes. So this represents ventricular depolarization. So that means the ventricles are contracting. Now, our normal cardiac cycle obviously includes lub-dub, but mechanically it is systole and diastole. It is squeezing and then it's resting, filling. So the first part that's squeezing is the atrium, that's the P wave. Then we go to the QRS ventricles that are squeezing. So it's very important that we have a QRS wave present after a P wave because that is our normal cardiac cycle. And just a side note, sometimes you'll see QRS complexes that look a little different. Sometimes they're inverted, sometimes they're really tall, really low, but they're still a QRS complex. There's still ventricular contraction, but maybe there's some type of abnormality. Maybe there was like the muscle tissue had some ischemia in the past, and so it looks a little funny, or maybe there's like an electrolyte imbalance, but this still is a QRS complex. Then we have our T wave. So our T wave comes after the QRS complex, and that represents ventricular resting or filling, aka repolarization. So this is a time where the ventricles are filling with blood, getting ready for the next squeeze. And then the U wave. You don't really see the U wave, so this will probably be the last time we talk about it. But the U wave represents the Purkinje fiber repolarization. So it's that very, very last moment where the ventricles are about to squeeze the blood out. And then the whole process starts all over again. So here it is in action. You can see how the electrical conduction system follows these waveforms. Then we have our intervals. So we have a PR interval, QRS interval, and a QT interval. So you can see where they start and end here. Now these are important because there are normal ranges for these intervals. So for example, the PR interval is the measure of time to depolarize the atria and travel to the ventricles. So the time that it takes the atrium to squeeze and then the message needs to be sent to the ventricles is our PR interval. Now this PR interval is going to become important when we talk about heart blocks. So the normal range for this is 0.12 to 0.20 seconds. Okay, we're talking about fractions of a second. So we want these PR interval to be within that amount of time. Then we have our QRS interval. So this is the ventricular contraction, the depolarization of the ventricles. Normal is 0.06 to 0.1 seconds. Then our QT interval. So this is the measure of time it takes for the ventricle to depolarize and then repolarize. So the time it takes to squeeze and then fill to get ready to squeeze again. So this is going to be less than 0.52. So this is a depiction of the phases of the cardiac cycle. It includes mechanical and electrical conduction. So you can see when systole begins and then when diastole begins and in its relationship to the waveforms PQRST. So take a look at that. So back to our electrocardiogram and the paper that we use. So this paper is special. It has lots of boxes on it. We have little boxes and then we have bolded boxes, and this is representing time. So the axis, horizontal axis, is time in seconds, and the vertical axis refers to amplitude, so like energy, electricity. So the higher up, the more amplitude it has. So next is how to calculate the heart rate using this ECG paper. So you see this paper, it has the bolded boxes and then the little boxes inside. So we're going to use a 6-second strip. And what is the significance of this 6-second strip? Well, we know that 60 seconds is 1 minute. So if you have a 6-second strip, we just multiply it by 10, and that's going to give us a heart rate in 1 minute. So if you look at this paper here, you can see that it has been marked off with 3 seconds. And if you counted each of these bold boxes, it's going to be 15. So 15 bold boxes equals 3 seconds. So 30 bold boxes equals 6 seconds. So you don't have to count all these boxes if this was a real life scenario, because the ECG paper already comes marked for you. It will either come every 3 seconds with like this little black line, or it'll be at every 6 seconds. So that's how you know, okay, all you have to do is count and then multiply by 10. So what are we counting? So we are counting the QRS complexes, specifically the R's, the R to R. So this tip right here, that's the R, so that's what we're going to count. So for this strip, it's a 6-second strip. We're going to count the R's. 1, 2, 3, 4, 5, 6. So 6 R's, 6 technically that's referring to ventricular squeezes, right? So that is going to be 60. So this strip is a heart rate of 60. So that's one way you can calculate the heart rate. Next, we want to see if the rhythm is regular. And there's a couple of different ways you can do this. We're going to talk about marching out the rhythm, which is counting boxes, and using calipers. So calipers are pictured here, and it's this little device. So what you do is you stretch it open. You could do, you can measure from R to R or P wave to P wave, but here in this picture you can see R to R. So you spread it open from the first R to R, you lift up the calipers and you compare it to the next R to R. And if it is exactly the same distance, then we know that rhythm is regular. The next technique to identify whether the rhythm is regular or not is by marching out the waveforms. So you see here in this top one, if you counted more or less the boxes in between the R's, and then if they match the number of boxes between the following R's, then that would mean the rhythm is regular. So you can see here in this example, 1, 2, 3, 4, 4 whole boxes, and if you add this one to here, that would be 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5, and so on. So this is a pretty regular rhythm. The one below here, you can see right away, you don't even have to count the boxes. It looks irregular. You can see between here and here and here and here, they're not the same distance apart. So that's called marching out the waveforms. So these are the steps that you should take when you are interpreting an EKG rhythm. So you're first going to see what the rate is. Is it fast, slow, or normal? Then you're going to check to see if the rhythm is regular. Then you're going to piece it apart. Are there P waves? Are there QRSs? Are there T waves? You can then measure the intervals to see if they're within normal limits. Then check to see if there's a P wave for every QRS, if there's a P wave before every QRS, and if there's a QRS after every P wave. So all of that are going to give you the clues to determine what type of rhythm you have. Here we have normal sinus rhythm. So this is going to be an electrical impulse that originates in the sinoatrial node. The rate is going to be between 60 and 100 beats per minute. So let's count it. If we're assuming this is a 6-second strip, we're going to count the R's. So 1, 2, 3, 4, 5, 6, 7, 8. So 8 times 10 is 80. So with this strip, it's going to be an 80 heart rate of 80 beats per minute. So regular atrial and ventricular rhythm. So that means if you took calipers or you counted the boxes in between each R, it's going to be the same, okay, the same interval. And if you counted, so this is the P wave here, if you measured between each P wave, those will also be the same. So that is regular atrial and ventricular rhythm. And then if you see here, this is a P wave, this is a QRS, this is a P wave, this is a QRS, P wave, QRS. They are coupled together. So all together that makes this normal sinus rhythm. So now that we know what normal sinus rhythm is, let's talk about our dysrhythmias. We're going to start off with sinus bradycardia. So sinus bradycardia, as you know, is a heart rate below 60, and it's also a regular rhythm. So if you look at this 6-second strip here, you can see that if we count the R's, 1, 2, 3, 4, we multiply that by 10. This strip is going to be a heart rate of 40. And every P wave has a QRS. Okay, so this is essentially sinus rhythm, just slowed down. And of course, this impulse is going to originate in the SA node, making it a sinus bradycardia. So what causes this dysrhythmia? Hypoxia, so not enough oxygen circulating. Hypothermia, so being really cold. When we're sleeping or we're very relaxed, our heart rate will naturally slow. Well-trained athletes will sometimes have bradycardia, and that is their baseline, and that is a perfectly okay for that type of patient to have. Hyperkalemia, so high levels of potassium. Performing the Valsalva maneuver, so like bearing down, can slow your heart rate into bradycardia. And then we have our cardiac diseases. Remember, when you have something wrong with the conduction or the tissue, that can lead to a dysrhythmia. So these things can lead to sinus bradycardia. Anything wrong with the SA node can lead to bradycardia, cardiomyopathy, myocarditis, MI, and heart blocks, which will come to be significant later. Medications, so medications that we give the patient to slow the heart can sometimes go a little overboard. So like our beta blockers, digoxin, calcium channel blockers, lithium, and some antiarrhythmics can also cause bradycardia. So then we see here, so what is the treatment for bradycardia? So remember our asymptomatic versus symptomatic. So if a patient has a dysrhythmia and they're asymptomatic, then we're likely just going to observe. So this is no different. So if a patient has sinus bradycardia and they're asymptomatic, then we're just going to watch them. But if they're symptomatic, meaning they're showing signs and symptoms of decreased cardiac output, because decreased cardiac output is the complication of all dysrhythmias. That's the potential complication that we're trying to avoid. So if a patient is lightheaded, they're dizzy, they feel palpitations, and then you look on the monitor and they're bradycardic, then you need to do something about it. So the medication of choice to treat bradycardia is going to be atropine. Atropine 1 milligram IV push. So if medication is not effective, then the patient may need a pacemaker, but we're just generally going to say atropine and possible pacemaker, depending on the patient's symptoms. So here we have in this picture, we have the vial. So this is where you would actually draw it up and administer it. And then we have the crash cart version. So if you have a patient that is in cardiac distress and you call a rapid response, crash cart's going to come, and if they become severely bradycardic, you can push atropine as part of your emergency medications. So next is sinus tachycardia. So sinus tachycardia is a regular rhythm that has the same characteristics as normal sinus rhythm, except that the rate is greater than 100. So let's see what our rate is for this 6-second strip. So let's count the R's. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So we're going to multiply 12 times 10, and we're going to get 120. So this 6-second strip is a heart rate of 120. So causes of tachycardia: fever. Our higher metabolic rate, we don't feel good, we have fever, that's going to lead to tachycardia. Anemia, so you don't have a lot of red blood cells circulating that are carrying oxygen, so the heart is going to begin to compensate by beating faster. Hypovolemia, same idea. You don't have a lot of fluid volume, not a lot of blood volume circulating. Heart is going to compensate. Pulmonary embolism, we're going to talk about that later. Caffeine, nicotine, and other stimulants, and even alcohol can raise your heart rate. And then tachycardia can be a response of normal physiological activities. So you're exercising, you're going to have your heart rate raised because your body wants to increase that cardiac output. Pain can raise your heart rate, stress, strong emotions like fear and anxiety. Cardiac conditions like MI, heart failure, shock, and pericarditis. Medications, so atropine. We give atropine to treat bradycardia to bring up that slow heart rate, but we could also kind of overdo it and then the patient could become tachycardic. Dopamine, dobutamine, epinephrine, and amphetamines all can raise the heart rate. So how do we treat tachycardia? So first off, if we can treat the cause, then let's do that first. So if the patient has a fever, let's give some Tylenol, antipyretic to bring that fever down. If the patient's anemic, then maybe they need a blood transfusion. Hypovolemia, we need to replace that fluid volume. So we're not always going to give a medication to lower the heart rate. Just depends on the situation. Now, if it is a situation where we can't do one of those things, then yes, we can give a medication such as a beta blocker or calcium channel blockers. Next up is supraventricular tachycardia, or SVT. So one thing to note is that this is an umbrella term. So supraventricular means above the ventricles. So this is talking about atrium dysrhythmias. So anything that's originating in the atrium is considered a supraventricular tachycardia if the heart rate is above 100. So all of these are considered types of SVT. So sinus tachycardia, atrial fibrillation with RVR. RVR means rapid ventricular response. Regular ventricular rate, atrial flutter, and junctional tachycardia. So all of these things originate in the atrium. That means the action potential is originating in the atrium and it's above 100. So that makes it an SVT. So let's look at our 6-second strip here. You can see that it looks like sinus rhythm. They have narrow QRS complexes and there's a lot of them. And in this SVT, the P wave kind of disappears. It doesn't mean that it's not there, but the rate is so fast we can't see it. So let's count it. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. So 17 times 10 on the 6-second strip is going to be a heart rate of 170. And this is considered continuous SVT with a heart rate of 170. So this says continuous. So SVT can also be paroxysmal. So down here, paroxysmal SVT, that means it's intermittent. It comes and it goes, but it's not sustained. So moving on. Okay, so it says originate in the atria, signals bypass or corrupt the AV node checkpoint. So if you remember, the electrical impulse starts in the SA node and then it goes down to the AV node. The AV node is the gatekeeper, so it kind of slows it down and then it lets it move on. So there's something wrong there. That AV node it's being bypassed, and so now we're getting this really fast rate. So what's happening is the ventricles are contracting before they're properly filled, which can lead to decreased cardiac output. These are the types of SVT, like I said. Paroxysmal SVT is commonly caused by an electrolyte imbalance. Remember that. So if you have a patient that's experiencing these intermittent episodes of SVT, you want to make sure that their labs, their electrolytes look okay and kind of look in to see why they're off. Maybe the patient's on diuretics and they're not taking their supplement. Maybe their potassium is low because of their Lasix that they're on. So that can lead to SVT. So that's something that you want to remember. So the treatment. So this is going to be based on symptoms and underlying rhythm. So we can give medication like adenosine IV push. Okay, so the algorithm says that we give 6 milligrams for the adenosine, and then the following dose is going to be 12. So the purpose of adenosine is to slow down the heart rate temporarily so that we can see what the underlying rhythm is. And an example of an underlying rhythm, it could actually be a fib hiding in there. We just can't see it because it's so fast. So that is going to determine how we treat this rhythm. Okay, so what do you need to remember for SVT? So again, you want to remember that paroxysmal supraventricular tachycardia, or SVT, is commonly caused by an electrolyte imbalance. Okay, so you want to remember that. Then you also want to remember, and I pictured a little crash cart here. On the crash cart, there is a defibrillator. So patients that have SVT that are symptomatic, uncontrolled, should be on a cardiac monitor. You should have a defibrillator nearby just in case, and the patient should be NPO because they might need a procedure. Okay, so keep that in mind. Remember the dosages for the adenosine. You always start with 6 milligrams. You don't start with 12, you start with 6 milligrams. Next, onward to atrial fibrillation, or AF. So this dysrhythmia is chaotic, it's asynchronous, but that electrical activity is starting in that atrial tissue. So in the SA node, we have these special cells that fire to create the impulse, but sometimes one, two, or more cells kind of migrate around the atrium. They leave the node and then they just fire at will, and it creates this atrial fibrillation. So remember that fibrillation is fibrillating, it's quivering. So the atrium are quivering, they're not really squeezing. So that blood really isn't moving out how it should. So there's not going to be any P waves because it's quivering. And remember, the contraction of the atrium is what makes a P wave. So QRXs are usually going to be narrow with irregular R to R intervals. So you see we have two types here. The top one is controlled atrial fibrillation. So that means it has a rate of less than 100. Okay, so you can see here if we count the R's, 1, 2, 3, 4, 5. 5 times 10 is going to be 50. So that rate is 50. And we don't count the P's because it's impossible for us to count all those little quivering lines because there are no P waves. This B1 is uncontrolled AFib, and when it's uncontrolled with a rate of higher than 100, we call that a rapid ventricular rate or rapid ventricular response, RVR. So this patient has atrial fibrillation with RVR. So if we counted these R's, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. So this has a heart rate of 17 times 10, so 170 beats per minute. That is very fast. So these patients with atrial fib, when it is in rapid ventricular response, can experience syncope, palpitations, and shortness of breath. So that is symptoms. So that's symptomatic. This is the most common arrhythmia in the world. This leaves the patient very high risk for stroke because when the atrium quivers like that, it's not emptying out as it should, and blood begins to pool in the atrium. And our blood isn't meant to pool. It's supposed to be on the move constantly. And when it starts to pool, it can clot. And those clots will travel through the heart and can end up in our brain and can cause a stroke. So patients with atrial fibrillation, it can be short-term or chronic. They can have intermittent AFib, or it can be chronic where they live with it for their entire life. So causes. Age is on the top of the list as being a risk factor for AFib for the same reason of dysrhythmias in general. That's because as we get older, those little cells in the SA node, they start to die off, and sometimes they do migrate around, so that puts you at high risk for getting AFib. Cardiomyopathy, pericarditis, pretty much any type of heart muscle tissue issue. Valvular disease, hyperthyroidism, hypertension, obesity, diabetes, chronic kidney disease, cardiac procedures, coronary artery disease, all of those things can kind of result in AFib. So the treatment, we want to control the rate. That's going to be our number one mission. If the patient is in RVR and rapid ventricular response or rapid ventricular rate, that means that we're losing cardiac output. So we really need to slow that heart rate down. And we're going to use digoxin, beta blockers, or calcium channel blockers. Patient also needs to be started on an anticoagulant because of the high risk of stroke. So anticoagulant is also going to be on our priority list. Once the rate is controlled and the patient has been started on an anticoagulant, then we can see if we can convert that rhythm. And it really depends on the patient. Sometimes the patient can live with AFib and they take medications just to control the rate. But sometimes we can convert it. So antiarrhythmic medications, cardiac ablation, where they go in with a little probe and they kind of zap the cardiac tissue, whichever area is causing these abnormal action potentials, and pretty much we're killing little pieces of the heart tissue with an ablation. Or cardioversion. If a patient is in AFib with RVR, so the rate is really high, patient is symptomatic, then we can do a synchronized cardioversion. And we talk about cardioversion in another lecture. Complications, essentially, just like any dysrhythmia, you can experience loss of cardiac output, which is like I said before, the complication we're trying to avoid the most with any dysrhythmia. And with atrial fib, high risk for blood clots, so we want to avoid stroke. So just some information here for your knowledge down in this green box. If you were able to count the atrial rate, it's going to be about 300 and 600 beats per minute. So you can imagine that atrium is just quivering, no blood is really forcefully coming out of it. So the heart rate or ventricular response is determined by the AV node's ability to accept and transmit the impulses to the ventricle. So that's why we said that there's something wrong with that AV node. It's not able to slow down that rate as it should. So again, if the heart rate is above 100, then we consider that uncontrolled AFib. Okay, uncontrolled AFib with RVR. Now these patients will sometimes be on a diltiazem infusion. Just a little reminder here on a lot of these cardiac medications, they can cause hypotension. So if you have a patient with AFib and they're on continuous cardiac monitoring, so you're looking at the rhythm, you're making sure that they're not too high. If the patient has a controlled AFib and they're on if they're on a diltiazem infusion and their blood pressure starts to drop, you need to do something. You need to call the provider, because most likely either the dosage needs to be decreased or they need to change the medication. Even if it's working for that patient, you cannot continue it if the patient is hypotensive. Okay, so diltiazem infusion on a patient with AFib, you need to monitor that blood pressure, and if it gets too low, you need to let the provider know. Okay, now we have atrial flutter. It's AFib's cousin, right? Atrial flutter. So let's look at this strip and let's count the rate first. So we're going to count the R's. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 10 times 10 is 100. So this rate is 100 beats per minute. Now you can see this one looks pretty regular. So atrial flutter has a tendency to be regular, but not all atrial flutter is regular. So just know that. So here we're going to see these sawtooth-like waves, and you can see they're pretty uniform. So that means that that little cell, that rogue cell that left the SA node, it's the same one firing. That's why they look uniformed. It's the same node firing, but it's not inside the SA node. It's like a rogue one. And we call those F waves because they're not P waves. We call them F waves, and they look like the sawtooth like pictured here. So let's see. So atrial rhythm produced outside of the SA node, no P waves, only F waves. The rate can actually go all the way up to 350. So you can have atrial flutter with RVR also. This can be chronic or short-term. Causes: acute MI, valve disease, thyrotoxicosis. Thyrotoxicosis is when you have really high levels of thyroid hormone. COPD, procedures in the chest, and digoxin toxicity. The list actually is pretty long, but those are just some of the causes. Treatment: just like AFib, we want to control the rate. Okay, when you're in RVR, no cardiac output. There's going to be a lot of issues with perfusion. So we want to control the rate with beta blockers, calcium channel blockers, digoxin, very similar to AFib. And then after we control the rate, we can possibly give an antiarrhythmic to chemically convert it back to sinus rhythm, hopefully. Or the patient could maybe benefit from a cardioversion, but cardioversion is not the first line treatment. Okay, first we're going to do rate control, and then after the rate is controlled, then we can move on to an antiarrhythmic. Next, premature ventricular contractions, or PVCs. So these PVCs are wide and atypical. It's kind of like a bizarre looking QRS complex. So these impulses originate in the ventricle because they are premature ventricle contractions. And they are going to originate below the bifurcation of the bundle of His. So the bundle of His is right here on the septum of the two ventricles, right in the middle. So there's like this rogue random impulse that just triggers there, and it causes this extra beat, this extra ventricular contraction. And you can see on these two strips here, the top one is a regular sinus rhythm, and then the bottom, there's just like this random QRS that's really wide and bizarre. And then there's a pause, and then it just goes back to normal. So that is a premature ventricular contraction. They can be benign. Me and you can have that. If we were hooked up to a monitor, it might show some PVCs every now and then, not clinically significant. Or they can come as a result of hypoxia, MI, cardiomyopathy, electrolyte imbalance, if you drink a lot of caffeine, hypertension, and if you do drugs. So we're not really too concerned unless you have a lot of PVCs next to each other. And we'll see what it can turn into next. So the treatment for this is to correct the cause and possibly antiarrhythmic therapy, but that's rare. That's not very common. Okay, so look what it can turn into. If you have 3 or more premature ventricular contractions in a row that are fast, so more than 100 beats per minute, we're going to call that VTAC. We're going to call that ventricular tachycardia. So this is an unstable rhythm, and it could be sustained or non-sustained. So this means that your patient can be normal sinus rhythm, and then all of a sudden they go into VTAC for 10 beats, 5 beats, 3 beats. So that the monitor tech that's monitoring your patient will call you and say, hey, your patient had a run of VTAC for 5 beats. So if it's a short run of VTAC, we don't have to do anything urgent, but we do want to see if there's anything in the patient's medication and their history and their labs that can be causing it. And usually per facility protocol or even per MD order will tell you when the doctor wants to be notified for runs of VTAC. So sometimes the cardiologist, if you have a run of 5 beats, they don't really care. Like they don't want to be called at 2 in the morning if they have a run of 5 beats. Some doctors say run of 10 beats or more, then call the doctor. So that's going to be kind of provider specific, facility specific, but you need to know that VTAC precedes VFib, and VFib can lead to sudden cardiac death. So we don't want to see VTAC on the monitor. This type of ventricular tachycardia is going to reduce filling time. Okay, the ventricles aren't going to have enough time to fill with blood because they're contracting too fast, and that's going to lead in a rapid deterioration of the patient because they're not going to have a lot of cardiac output. And you may have VTAC on the monitor and the patient may be pulseless. So you can have pulseless VTAC. So of course, if you don't have a pulse, that's a medical emergency. But let's look at the causes. Hypovolemia, hypoxia, acidosis. So you can see that these patients are usually sick, right? If a patient is really hypovolemic, they're hypoxic, they're in acidosis, they're going to be at risk for having ventricular tachycardia. And then look at this. All of these electrolyte imbalances, hypoglycemia, hypothermia, toxins, cardiac tamponade, MI and PE can all lead to VTAC. So what is the treatment? So remember this, guys, okay? The treatment is going to be based on the patient's representation. So if the patient is in ventricular tachycardia with a pulse, then we are going to give medication. We're going to give amiodarone, which is an antiarrhythmic. We're going to replace whatever's causing the cause, so electrolyte replacement. And the patient may need a cardioversion if they're symptomatic. So we just don't go zapping people, okay? So it has to be for, for a reason, and they're sedated for cardioversion. Now, if the patient has pulseless VT, pulseless, they don't have a pulse, you're going to start CPR right away. You're going to get a defibrillator. And after the shock, we are going to do our ACLS emergency cardiac meds, so epinephrine and other antiarrhythmics like amiodarone. And just a side note on amiodarone that you should write down. So amiodarone, this medication, this antiarrhythmic, you want to be looking out for dependent edema on patients. So we're not talking about this emergency patient who just received amiodarone, but this is patients who may be on a drip of amiodarone. You know, they're stable, you're watching them. This can cause fluid overload. So you want to make sure you tell the doctor immediately, report it to the provider if you see dependent edema forming on a patient who is on amiodarone. So this is what VTAC looks on the monitor. So it can look kind of several different kind of waveforms here. So the first one we consider like headstone. The next slide has a better picture of that headstone, but they have a high amplitude. They're wide and they're kind of bizarre. Usually you can't discern a P wave. So again, patients that have a pulse, you are not going to start CPR. But this is a shockable rhythm, so if they do not have a pulse, then you're going to start CPR and you're going to prepare the defibrillator so that they can get shocked. This is examples of VTAC. They're all VTAC here. You can see this top one looks more like that tombstone look. Then lastly, we have our VFib, our ventricular fibrillation. This is a lethal dysrhythmia. So if you look on the monitor and it is a true VFib, that patient does not have a heartbeat, they're unresponsive, there's no blood pressure. So you need to start CPR immediately. It is a shockable rhythm, so it's just very similar to VTAC. You're going to check for pulse, start CPR, get the defibrillator ready, and administer that shock. And you're going to give epinephrine 1 milligram every 3 to 5 minutes, followed by amiodarone 300 milligrams IV push. So that is going to be your emergency meds. Causes very similar to VTAC because we know VTAC can turn into VFib. So again, VFib, you can defib. Okay, it's a shockable rhythm. This is what it looks like on the monitor. It has low amplitude, so you can see VTAC was pretty high, VFib pretty low, squiggly line. That squiggly line doesn't have any P waves, no QRSs, because the heart is just quivering. You can see in this picture just quivering. There is no blood moving in and out. There is no cardiac output. This is going to lead to death pretty quick. Next, we're going to talk about asystole. And pictured here is a straight flat line. So asystole can either look like this or it can be a little wavy, low amplitude, but sometimes it has a little body to it. So this is no measurable electrical activity originating from the heart, and the first thing you want to do if you have a patient with this on the monitor is to check your patient, because this could be a false reading. Sometimes if the little leads fall off the chest, the stickers, then it could look like an asystole, or maybe it became unplugged. That will also look like asystole. So really important that you assess your patient first and you check their pulse. So once you have confirmed that indeed they don't have a pulse and they're flat line on the monitor, then you're going to start your interventions. You are not going to defibrillate asystole because this is not a shockable rhythm. So why don't we shock asystole? So there has been a lot of studies and research on this because many years ago, yes, they used to defibrillate asystole, but studies have shown that this is not an effective way to restart the heart. So we don't do that. So treatment is going to be CPR. And then we can start our ACLS algorithm, which starts with epinephrine, and of course then treat the cause. So the cause of asystole could be, there are unlimited reasons, but sometimes your patient will go into VTAC, VFib, and then asystole in that order. Sometimes not. Sometimes it just goes straight to asystole. So we know what the cause is, we're going to treat that and then continue our CPR. And then sometimes when the patient has ROSC, or return of spontaneous circulation, then they may be in VFib or VTAC, and then that is a shockable rhythm, which we will then shock the patient. So that is asystole. So again, the main takeaway here is that it's not a shockable rhythm. You immediately start CPR after checking for pulse, and then you start with epinephrine. And just a little side note, how I mentioned that this flat line sometimes isn't a straight flat line. Sometimes it's a little bit tiny wavy, but it is still considered asystole. However, sometimes ventricular fibrillation has really, really low amplitude, and sometimes it can actually be VFib and not asystole. So that is just a side note. You don't have to know that for the exam, but just know that you want to confirm that asystole dysrhythmia before you start your interventions. Next is pulseless electrical activity, or PEA. So this patient will have a rhythm on the monitor, but actually the heart is not physically pumping. So this patient is in cardiac arrest, and we're going to treat this like a systole. So we're going to do CPR, epinephrine, and then we're going to treat the cause. So how do you know if your patient is in PEA? So actually the rhythm can look kind of like a real rhythm. It can be regular, irregular, it can be fast or slow, it can have narrow or wide complexes. It may just look like a normal rhythm, but it doesn't look right. You can see this in the picture. It just doesn't look, very fine. It kind of looks a little blurry, a little squiggly. So the takeaway from pulseless electrical activity is you always check your patient. If you have a patient that's sleeping and they look a little, they're not really moving, but they have a rhythm, you always want to check to make sure they still have a heart rate, they still have a heartbeat. So you're going to check the pulse. Again, PEA, pulseless, CPR, epinephrine, check the cause, very similar to what we do for asystole. So now we're going to begin to talk about our heart blocks. So all heart blocks are going to be related to there's something wrong with the AV node. Okay, so this you have to remember the conduction of the heart. So remember that in normal conduction, the impulse will start in the SA node. That is here, I'm going to circle it. This is the SA node in the atrium. And then from there, it's going to travel down to the AV node. When it hits the AV node is going to kind of slow it down to give it a chance, to give the ventricles a chance to fill, and then it's going to contract. Okay, so that's how it should normally run. With all heart blocks, there is something wrong with the AV node. So those signals from the SA node are not coming through as they should. Okay, so either every other one comes through, every third one, every fourth one, or maybe that's not going through at all. So the ventricles are not getting that message to contract when they should be. That is the whole problem with heart blocks. Okay, so why is this happening? This is happening because the AV node's blood supply has been compromised. So if you remember, and you can look at this picture down here, the right coronary artery right here is what supplies the AV node with rich oxygenated blood. So something happened, okay, there's some kind of infarction, some kind of blockage that is not allowing that oxygenated blood to go down to these branches that are more distal. So that is going to affect the ability of that AV node to function because it's not getting oxygen. So that is the whole problem. Compromised blood supply is going to lead to ischemia. It's going to lead to AV node tissue death. And the severity of that tissue death is going to determine what type of heart block you see. Okay, so these electrical impulses are going to need to find an alternative pathway because that electricity needs to go somewhere. So there's 4 types of heart blocks: first degree, second degree type 1, second degree type 2, and third degree. So the primary causes of heart blocks are going to be acute coronary syndrome. So this is going to be related to blockages. Essentially, there's an obstruction in the vessel. Other causes of heart blocks could be electrolyte imbalances and medication toxicity. So keep it really simple. Heart blocks caused by MI or acute coronary syndrome, and electrolyte imbalances and medication toxicities. So before we start talking about the heart blocks, let's review the PR interval and why is it significant. So you can see here the PR interval starts at the beginning of the P wave, which was when the atrium squeeze or contract. and then it ends at the beginning of the QRS complex right before there's ventricular contraction. So in between here, electrically, is when the SA node fires. So then that makes the atrium contract, and then that impulse travels to the AV node. And so that is what's going on in the PR interval. So with the heart blocks, we know that that is the issue. So we're going to focus on this PR interval. So regular interval is going to be 0.12 to 0.2 seconds. So now let's look at our ECG paper. So here's our ECG paper, and you see that this one small box that I circled here is 0.04 seconds. A large box, the bolded box, is 0.2 seconds. So when we're looking at a rhythm, we're going to look at the PR interval and see whether it is bigger than this bolded box, because that would make it prolonged, right? Prolonged PR interval, or if it's within normal range. So that is something that you're going to need to identify in order to find out which type of block you're actually looking at. So now we're going to look at our first heart block, which is going to be first degree AV block. Now I didn't mention this before, but any type of heart block will lead to bradycardia. Okay, it's going to lead to a heart rate that's been slowed. Okay, so with this one, if you take a look at this, it kind of looks like sinus rhythm. Okay, it's regular. You see a P wave with every QRS, and if you count it in between the R's, it's going to be equal. So a first degree AV block looks very similar to normal sinus rhythm, except that the PR interval is prolonged. So if we were to measure the PR intervals, like here, it's going to be more than 0.2 seconds. And if we measure every PR interval that we see as this rhythm as an example, they're going to be exactly the same. So with first degree AV block, the PR interval is prolonged, so it's going to be bigger than a bolded box, and they're going to be the same. So it's going to kind of look like normal sinus rhythm, except that the PR interval is longer. So what this means is that every impulse that the atrium, that SA node is firing, is going through the AV node. It just takes longer. Okay, so every impulse is getting there and it's going through the AV node. It just takes longer. That's what a first degree AV block is. So the treatment for this is usually nothing, because this isn't a continuous rhythm. A patient may have first degree AV block and then it goes away. It's very rare that it's continuous, and if it is continuous, then it may cause the patient to have bradycardia, a little bit below normal range of the heart rate, but it's not that common and it's really not going to cause an issue. Okay, so first degree AV block looks like sinus rhythm, except the PR interval is prolonged, so longer than 0.2 seconds, but they're uniform. Each PR interval that you see are going to be exactly the same. Treatment, you don't have to do anything because patient's probably not going to be symptomatic. And something to remember, this one, if the R is far from P, then you have first degree. Next is second degree AV block type 1. We're still looking at that PR interval. This is also called Wenckebach or Mobitz 1. So with this one is a little bit different than the previous one, because not all of those atrial impulses are going to get through the AV node. Okay, the previous one, first degree, all of them were going through, they were just delayed. But this time, some of them aren't even going to make it through. So we are going to have more P waves than QRSs, and the PR interval is going to get progressively longer until it drops a QRS. So if you look at this picture, you can see, okay, in this one, the PR interval is a little bit longer. You can see it's longer than a bolded box, and then it gets longer here, and then it keeps getting longer, and then there's a gap here because there is no QRS. This will show on the monitor as a lower heart rate. And again, this one is usually intermittent also. So you don't typically have a second degree AV block type 1 continuous on the monitor. It just kind of shows up and then it goes away. And again, this one's same thing. It's treated only if symptomatic, and the symptoms are going to be related to decreased cardiac output, bradycardia. So we're going to give atropine just like we would with a sinus bradycardia. So if by chance the patient is symptomatic and we gave atropine and it really isn't effective, then the patient may require temporary pacing. That would be with a transcutaneous pacer, and we'll go over that later. So something to remember, longer drop, then you have Winky Bach. Okay, so this is second degree AV type 1. Next we have second degree AV block type 2. This one is also known as Mobitz type 2. So with this one, we have our PR interval exactly the same. So you can see the interval are uniformed, exactly the same. But with this one, we drop QRS complexes. And if you look at the strip here, you should see, look, this is a P wave here. This is a little T wave here, but there's no QRS complex. It's missing. It got dropped. So this one can lead to third degree AV block, which is a potential life-threatening dysrhythmia. So we want to be really careful with second degree AV block type 2. So with this one, it's going to depend on the patient's symptoms. So if the patient is symptomatic, then we are going to place them on temporary pacing. Transcutaneous pacing can be done at the bedside. It's fast, so we can do that. Or they can have a pacemaker inserted. It just depends on how severe this is. So with this one, some of the P's don't go through, then you have Mobitz 2. One way to remember that. So our final block here is third degree AV block, also known as CHB for short, complete heart block. So this is where there are 0 impulses going through that AV node. So the SA node is firing and the atrium are contracting, and then the ventricles are just contracting on their own. There's no synchrony there. So because there's no communication between the atria and the ventricles, what we see on the strip are just going to be a bunch of P waves and a bunch of QRSs. They're not next to each other how they should be. The QRS doesn't have a P wave next to it every single time. So this is bad because the blood coming into the heart, it has to happen in order. You know, the atrium contract, pushes it into the ventricles, ventricles contract, and then that's the way the system works. So if you have atrium contracting on their own and ventricles contracting on their own, it's just a matter of time before the patient doesn't have adequate cardiac output. So symptoms are going to be treatment is based on symptoms. So if they are hypotensive or short of breath, then we're going to want to do something. We want to treat the cause if possible. Again, transcutaneous pacing or permanent pacemaker, because all of these are going to result in bradycardia. Bradycardia is so slow that the heart may stop. So we just want to make sure that heart keeps going. And this little rhythm here, or this little rhyme, if P's and Q's don't agree, then you have third degree. So this slide are just some memory rhymes for you to remember which heart block it is, so you can read through this on your own. This is the heart block poem, very similar to the previous slide, just another way to look at it. Again, a different version of the heart block poem. And then this one is a story based on heart blocks. So it is a long read, but if your brain works this way to remember the heart blocks, I think it is worth the time to take a few minutes just to kind of read through it. So this is straight from your textbook, Table 29.8, Summary of Heart Blocks. So it gives you a nice little overview of each heart block, medical interventions, nursing interventions, and patient teaching. So this is a nice overview. All right, so let's talk about some interventions. So first is our transcutaneous pacing or TCP. This was mentioned in our heart blocks because this is appropriate for patients who are bradycardic and we're not able to, fix it another way. So this is temporary pacing and you put the pads on. This is the same pads that are used for like defibrillating from the crash cart. You put it on and there is controlled pulses of electrical current that is delivered to make sure that the heart gets that electricity it needs to keep on beating. So this is non-invasive. It goes on the outside of the skin. Nothing goes inside the body, and it is used for bradycardia. This is not the same as defibrillation or cardioversion. So we are going to place these pads both on the patient anterior chest, anteriorly and posteriorly. You are going to medicate with a sedative as ordered, if appropriate. You're going to monitor the patient's vitals, heart rate, and blood pressure, and also the rhythm, of course. You want to make sure the patient remains stable. And we are going to continue our continuous cardiac monitoring just to make sure that that rhythm change remains, that rhythm remains adequate. So they're no longer brady, they're in a normal range for their heart rate. Next is a pacemaker. So the pacemaker is also done for bradycardia, for slow heart rate, and this procedure is done in the cath lab. Pacer wires are placed in the atrium, ventricle, or both. It just depends on what the issue is with the patient. It's attached to a small pacemaker that is placed under the skin near the clavicle. So you see in this picture, it is right, let me show you, right here. And you can see that from the outside. So oftentimes when you are admitting a new patient and you ask them a bunch of questions about their health history and they don't mention a pacemaker, but then when you're doing your physical assessment, you find it and you're like, hey, you have a pacemaker, you didn't tell me. So make sure you're always checking. And if you see a little bulge there around this area, they probably have a pacemaker. So I included this screenshot from ATI because it shows the permanent pacemaker slash ICD discharge teaching. Very important that the patient goes home and they know what to do and what not to do with their new pacemaker. I went ahead and I highlighted some areas here. One is prevent wire dislodgement. So during the recovery period, about 1 to 2 weeks, they should wear a sling when out of bed and they should not raise their arm above the shoulder. That can dislodge those brand new placed wires in there. That would be bad. Take a pulse daily. If the ICD, if they have an ICD, delivers a shock, then even somebody touching the patient might feel a little electrical impulse, but it's not harmful. But you do want to warn them about it. Follow activity restrictions per doctor's order. So just read through these up, and here's another highlighted one. The use of household items is not prohibited. So what's that referring to? So when patients go home, they've heard that they can't stand next to a microwave. Okay, that is a myth. They can stand next to a microwave, but you shouldn't be near magnets. So, for example, an MRI. Some pacemakers are MRI compatible, but we always assume they're not. So you don't want to be putting a patient into a magnetic field that has a pacemaker. So if you have a pacemaker, if the patient has a pacemaker and they say they have the special one, they should actually have a card, a manufacturer card that has the make and model that we can then look up just to verify that yes, we can put the patient in an MRI machine or something like that. So for all internal pacemakers, again, we're going to monitor that blood pressure and heart rate because it's all about the pacemaker is there to maintain that heart rate. So we want to make sure that they have good cardiac output and that their heart rate remains normal. We're going to watch the rhythm on the monitor, make sure they're on continuous cardiac monitoring. You don't want to place any medication or patches or defibrillator pads over a pacemaker. Leave the pacemaker alone. And then post-operatively, we're going to monitor the incision site for infection, just like any other surgery. So, purulent drainage, increased redness, increased pain, all of those things should be reported to the doctor. Next is cardioversion and defibrillation. So what's the difference? So we have two types of cardioversion. We have an electrical one and a chemical one. So the electrical one is done with a machine and it is a controlled electrical discharge. That's one big difference from defibrillation. This is controlled. The energy is released at the peak of the R wave. So this is a synchronized cardioversion. And this is usually indicated for a patient who is symptomatic. Okay, so we don't do this for a patient that is symptomatic with an arrhythmia. This is for symptomatic patients that might be hypotensive, shortness of breath, complaining of pain. If the patient has symptomatic tachycardic dysrhythmias with a pulse, okay, you're not going to do a cardioversion on somebody that has no pulse. So, for example, put a star, supraventricular SVT rhythms, such as atrial fibrillation with RVR, atrial flutter with RVR, or even ventricular tachycardia with a pulse. They can all have a cardioversion. Okay, so make sure you have that down somewhere. Now, chemical cardioversion. So this is going to use a medication. There's several different kinds of medications that can be used to convert the rhythm back to a normal sinus rhythm. So the patient has to be stable because this takes some time. And if the patient is unstable, then we're likely going to do an electrical cardioversion instead. So back to chemical. So examples of medications that can be used for this are diltiazem, adenosine, and amiodarone. So you want to be careful with these medications because what happens is the patient comes in, they have this rhythm that we're trying to chemically cardiovert. So they're hooked up to an IV infusion and they're getting a continuous IV drip. Those patients need to be on a continuous cardiac monitor that you are checking frequently. And you want to be really careful, one, for blood pressure, because these medications have a tendency to drop the blood pressure, especially diltiazem. So if your blood pressure begins to drop on your patient and they're on this drip, you need to tell the doctor about it because they may need to adjust the dose or they may need to change the medication. Even if it's working, I said this before, even if it's successfully um, converting that rhythm, if the patient is starting to have a really low blood pressure, that's incompatible with life. So you need to tell the doctor. Amiodarone. Patients with on amiodarone, they may develop dependent edema. Again, I mentioned this before. Big flag here. I'm mentioning this twice. Please make a note of it. Amiodarone can cause dependent edema. Again, that's something that we need to tell the doctor about. Then we have defibrillation. So this is an uncontrolled electrical discharge of energy anywhere during the cardiac cycle. So we don't have to wait until that R wave. We just hit the button and shock them. This is indicated for tachycardic dysrhythmias without a pulse. Okay, so you're only going to use defibrillation on VTAC and VFib without a pulse. Okay, without a pulse. You're not defibrillating anybody that has a pulse. An ICD, I mentioned this before, this can be combined with a pacemaker. This is implantable cardioverter defibrillator. So it's a little bit bigger than a pacemaker, but you can actually get a device that has a pacemaker and an ICD in one. And this is like a mini defibrillator. It's constantly checking and if a shock is needed, it will deliver it to the patient. Cardiac ablation. So this uses energy to kind of burn, aka ablate areas of the conduction system. So first things first, the patient needs a 12-lead EKG to identify where exactly in the heart is the problem located. So if you have these rogue cells that left the SA node and are somewhere in the atrium firing at will, then we need to identify where it is. Then a catheter is inserted and hopefully they get the right spot and they kind of burn that tissue. It's an electrical device hot enough, it burns it. And the idea is that we're killing those rogue cells so that they don't continue to fire these abnormal charges, making the heart do weird things. So this catheter ablation is a definitive treatment for tachydysrhythmia. So that means that it works when it works. And there's a low complication rate. This is also done in the cath lab. The post-procedure care is similar to a cardiac catheterization because we have to go in through an artery, usually in the groin or the radial in the wrist. So after this procedure, because the procedure was meant to fix the problem, right, to fix those abnormal beats, they shouldn't have that post-procedure. So if a patient who's just had a cardiac ablation reports irregular beats or other signs and symptoms of decreased cardiac output, that is not normal. They need to report that. Okay, so if they're saying, hey, you just taught them this discharge information and they're like, okay, so I should expect irregular heartbeats. No, that's incorrect. You should not expect that. You should call your doctor. So to wrap this up, cardiac dysrhythmias overall, generally speaking, we need to evaluate that ECG and identify the rhythm. So if you have a 5-lead, which is what we use for continuous cardiac monitoring on the floor, you'll need to get an EKG. You need a 12-lead EKG because that is more specific. It really identifies exactly where it is located on the heart. If the patient is asymptomatic, we are likely going to observe the patient, or we're going to choose an intervention where we can do it over time. It doesn't have to happen right in this moment. We can do it later today, tomorrow. It can be scheduled. Versus a cardiac dysrhythmia that is symptomatic. Symptomatic means that you are experiencing signs and symptoms of decreased cardiac output. That is urgent. Okay, that is your priority patient. So symptomatic patients, monitor those vital signs. We're going to monitor any changes in level of consciousness because if our brain is affected, that means it's pretty bad. The brain is being oxygen deprived. Diaphoresis, chest pain, poor peripheral circulation, nausea, vomiting. Those are all major signs and symptoms of decreased cardiac output. We also want to monitor electrolyte levels and cardiac enzymes. So we know many of these dysrhythmias can be caused by abnormal electrolytes. So we want to make sure those are normal. And oftentimes when a patient goes into these dysrhythmias, one of the treatments is to get an up-to-date lab, oh my goodness, get up-to-date labs. So draw labs and treat the electrolytes that are abnormal. And then cardiac enzymes such as troponin, serial draws, so draws over time to see, what's going on. Teaching. So, patients should immediately report chest pain or discomfort, take your medications as prescribed, and to notice those signs and symptoms of complications such as stroke. So, if they have atrial fibrillation, we know that they're at higher risk for stroke. So, definitely those are things that you need to educate your patient on. So again, signs and symptoms of dysrhythmias are going to be related to decreased cardiac output. This is going to include shortness of breath, pain, low blood pressure, fatigue, and death essentially. And of course, risk for embolic event, including stroke. So your nursing interventions, generally speaking, is to give those antiarrhythmic medications as ordered. Get a 12-lead EKG. They may need a cardioversion, so you should prepare for that. And you should be prepared to administer advanced cardiac life support. So what that's referring to is like patient goes pulseless, you're going to start CPR, defibrillate, and begin with that epinephrine. Or, if they're bradycardic, then we're going to administer that atropine. And then, of course, you're going to document the occurrence of the dysrhythmia. If you have to call a rapid response, then call it. And again, code blue, difference between rapid response and code blue. Code blue, no heartbeat or the patient stopped breathing. And then we have this little picture here to give you the difference between cardioversion and defibrillation. So I'm just going to go through this a little bit. So cardioversion, it's often an elective procedure. So you make an appointment and then you go in for it, you prepare for it. Patient does have some sedation in them. They could be loopy, a little conscious sedation. This is a synchronized cardioversion that follows the R wave. The joules are going to be less than defibrillation, 50 to 100 joules, and they need to be constantly monitored on that continuous cardiac monitoring. Now let's talk about defibrillation. This is an emergency. There's no time to schedule this procedure. This is going to happen when it happens. VFib and VTAC, those are the shockable rhythms. VFib, VTAC, prepare to defib. CPR, if they're pulseless. Okay, always check for pulse. No cardiac output. We're going to begin with a higher amount of joules, 120 to 200. That is going to be determined by the IED machine. You don't have to know that. Client will be unconscious, and of course, we're going to still continuously monitor them on the cardiac monitor. And safety for you, this is going to be a lot of jolt electricity. If you're touching the patient, you're going to get the jolt too. So make sure you stay clear before you use that defibrillator. And that concludes this chapter.